Acute kidney disease. Reported by Mara Vivian de Herrera. Acute kidney injury, AKI, is the term that has recently replaced the term ARF. AKI is defined as an abrupt, within hours, decrease in kidney function, which encompasses both injury, structural damage, and impairment, loss of function. It is a syndrome that rarely has a sole and distinct pathophysiology. Many patients with AKI have a mixed etiology where the presence of sepsis, ischemia, and nephrotoxicity often coexist and complicate recognition and treatment. Furthermore, the syndrome is quite common among patients without critical illness, and it is essential that healthcare professionals, particularly those without specialization in renal disorders, detect it easily. Acute kidney injury, AKI, is a clinical syndrome that complicates the course and worsens the outcome in a significant number of hospitalized patients. Recent advances in clinical and basic research will help with a more accurate definition of this syndrome and in the elucidation of its pathogenesis. With this knowledge, we will be able to conduct more accurate epidemiologic studies in an effort to gain a better understanding of the impact of this syndrome. AKI is a syndrome that rarely has a sole and distinct pathophysiology. Recent evidence, in both basic science and clinical research, is beginning to change our view for AKI from a single organ failure syndrome to a syndrome where the kidney plays an active role in the progress of multi-organ dysfunction. Accurate and prompt recognition of AKI and better understanding of the pathophysiologic mechanisms underlying the various clinical phenotypes are of great importance to research for effective therapeutic interventions. In this review, we provide the most recent updates in the definition, epidemiology, and pathophysiology of AKI. Classification of AKI includes prerenal AKI, acute postrenal obstructive nephropathy, and intrinsic acute kidney diseases. Of these, only intrinsic AKI represents true kidney disease, while prerenal and postrenal AKI are the consequence of extrarenal diseases leading to the decreased glomerular filtration rate, GFR. If these pre- and/or postrenal conditions persist, they will eventually evolve to renal cellular damage and hence intrinsic renal disease. The kidneys are responsible for a number of vital homeostatic processes, including the excretion of nitrogenous waste products, the regulation of fluid volume and electrolytes, acid-base balance, and the production of hormones important for blood pressure regulation, erythropoiesis, and bone metabolism. They are frequently affected by disease, both acute, occurring over days to weeks, and chronic, occurring over months to years. Acute kidney injury, AKI, formerly known as acute renal failure, has become an increasingly common cause of hospitalization with an incidence of 5–7% among hospitalized patients. Chronic kidney disease, CKD, reportedly affects 13% of adults in the United States and is associated with significant morbidity, mortality, and high costs of hospitalization. Furthermore, the recent advent of automatic reporting of estimated glomerular filtration rate, eGFR, with serum creatinine by hospital laboratories has resulted in more patients being identified as having impaired renal function. In order to provide the highest level of care for patients presenting with acute or CKD, the clinician should have a strong understanding of the fundamental issues relevant to their evaluation and management. The evaluation of the patient with kidney disease begins with a thorough history and physical examination. The clinician should identify early on whether the renal disease is an acute or chronic condition. If previous medical records are available for the patient, this can be determined by quickly reviewing prior laboratory testing, with particular attention given to serum creatinine, blood urea nitrogen, and urinalysis. Patients who present on admission with AKI should be questioned about recent symptoms, e.g., vomiting, diarrhea, edema, difficulty voiding, decreased appetite, weight changes, and events, e.g., changes in oral intake, new medications. History of nonsteroidal anti-inflammatory drug NSAID use, administration of intravenous contrast. Recent colonoscopy, that may help narrow the differential diagnosis of ACI. The presence of symptoms such as fever, rashes, arthralgias, epistaxis, and hemoptysis may be suggestive of an underlying systemic disease process such as vasculitis or other inflammatory conditions. For patients who develop ACI during their hospitalization, a thorough review of the most recent hospital events including episodes of hypotension, recent diagnostic and therapeutic procedures, and initiation of new medications should be performed. All patients presenting with acute or CKD should be questioned about symptoms associated with uremia, including fatigue, nausea, vomiting, pruritus, metallic taste, lethargy, and confusion, since the presence of these symptoms may indicate the need for dialysis. A past medical history should be elicited to identify a prior history of kidney disease or other systemic diseases that could be relevant to the current presentation. In patients with CKD, who may or may not be presenting with an acute kidney-related problem, the clinician should establish the underlying cause, chronicity, and severity of the kidney disease. Patients with acute kidney injury usually appear ill. Physical examination of patients with acute kidney injury is usually remarkable for hypotension, edema of the lower extremities, maculopapular rash, and rales on chest auscultation. Appearance of the patient. Vital signs: bradycardia with regular pulse, low blood pressure with normal pulse, pressure, skin, livedo reticularis, digital ischemia, butterfly rash, palpable purpura, maculopapular rash, track, marks, heme, keratitis, iritis, uveitis, dry conjunctiva, jaundice, band keratopathy, retinopathy, hearing loss, mucosal or cartilaginous ulcerations. Appearance of the patient. Neck. Neck examination of patients with acute kidney injury is usually normal. Lungs. Rales. Hemoptysis. Heart. Irregular rhythms, i.e., atrial fibrillation. Murmurs. Pericardial friction rub. Increased jugulovenous distension, rales, S3. Abdomen. Pulsatile mass or brute. Abdominal or costovertebral angle tenderness. Pelvic. Rectal masses. Prostatic hypertrophy. Distended bladder. Appearance of the patient. VAC. VAC examination of patients with acute kidney injury is usually normal. Genitourinary. Genitourinary examination of patients with acute kidney injury is usually normal. Neuromuscular. Neuromuscular examination of patients with acute kidney injury is usually normal. Extremities. Edema of the lower extremities. Anatomy and physiology. The kidneys lie on either side of the spine in the retroperitoneal space between the parietal peritoneum and the posterior abdominal wall, well protected by muscle, fat, and ribs. They are roughly the size of your fist, and the male kidney is typically a bit larger than the female kidney. The kidneys are well vascularized, receiving about 25% of the cardiac output at rest. External anatomy. The left kidney is located at about the T12 to L3 vertebrae, whereas the right is lower due to slight displacement by the liver. Upper portions of the kidneys are somewhat protected by the 11th and 12th ribs, link. Each kidney weighs about 125–175 g in males and 115–155 g in females. They are about 11–14 cm in length, 6 cm wide, and 4 cm thick, and are directly covered by a fibrous capsule composed of dense, irregular connective tissue that helps to hold their shape and protect them. This capsule is covered by a shock-absorbing layer of adipose tissue called the renal fat pad, which in turn is encompassed by a tough renal fascia. The fascia and, to a lesser extent, the overlying peritoneum serve to firmly anchor the kidneys to the posterior abdominal wall in a retroperitoneal position. The kidneys are slightly protected by the ribs and are surrounded by fat for protection, not shown. On the superior aspect of each kidney is the adrenal gland. The adrenal cortex directly influences renal function through the production of the hormone aldosterone to stimulate sodium reabsorption. Internal anatomy. A frontal section through the kidney reveals an outer region called the renal cortex and an inner region called the medulla. The renal columns are connective tissue extensions that radiate downward from the cortex through the medulla to separate the most characteristic features of the medulla: the renal pyramids and renal papillae. The papillae are bundles of collecting ducts that transport urine made by nephrons to the calyces of the kidney for excretion. The renal columns also serve to divide the kidney into 6–8 lobes, and provide a supportive framework for vessels that enter and exit the cortex. The pyramids and renal columns taken together constitute the kidney lobes. Renal hilum. The renal hilum is the entry and exit site for structures servicing the kidneys, vessels, nerves, lymphatics, and ureters. The medial-facing hilum are tucked into the sweeping convex outline of the cortex. Emerging from the hilum is the renal pelvis, which is formed from the major and minor calyxes in the kidney. The smooth muscle in the renal pelvis funnels urine via peristalsis into the ureter. The renal arteries form directly from the descending aorta, whereas the renal veins return cleansed blood directly to the inferior vena cava. The artery, vein, and renal pelvis are arranged in an anterior to posterior order. Nephrons and vessels. The renal artery first divides into segmental arteries, followed by further branching to form interlobar arteries that pass through the renal columns to reach the cortex. The interlobar arteries, in turn, branch into arcuate arteries, cortical radiate arteries, and then into afferent arterioles. The afferent arterioles service about 1.3 million nephrons in each kidney. Nephrons are the functional units of the kidney. They cleanse the blood and balance the constituents of the circulation. The afferent arterioles form a tuft of high-pressure capillaries about 200 m in diameter, the glomerulus. The rest of the nephron consists of a continuous sophisticated tubule whose proximal end surrounds the glomerulus in an intimate embrace. This is Bowman's capsule. The glomerulus and Bowman's capsule together form the renal corpuscle. As mentioned earlier, these glomerular capillaries filter the blood based on particle size. After passing through the renal corpuscle, the capillaries form a second arteriole, the efferent arteriole. These will next form a capillary network around the more distal portions of the nephron tubule, the peritubular capillaries and vasa recta, before returning to the venous system. As the glomerular filtrate progresses through the nephron, these capillary networks recover most of the solutes and water, and return them to the circulation. Since a capillary bed, the glomerulus, drains into a vessel that in turn forms a second capillary bed, the definition of a portal system is met. This is the only portal system in which an arteriole is found between the first and second capillary beds. Portal systems also link the hypothalamus to the anterior pituitary, and the blood vessels of the digestive viscera to the liver. Blood flow in the nephron. The two capillary beds are clearly shown in this figure. The efferent arteriole is the connecting vessel between the glomerulus and the peritubular capillaries and vasa recta. Cortex. In a dissected kidney, it is easy to identify the cortex. It appears lighter in color compared to the rest of the kidney. All of the renal corpuscles as well as both the proximal convoluted tubules, PCTs, and distal convoluted tubules are found here. Some nephrons have a short loop of Henle that does not dip beyond the cortex. These nephrons are called cortical nephrons. About 15% of nephrons have long loops of Henle that extend deep into the medulla and are called juxtamedullary nephrons. As noted previously, the structure of the kidney is divided into two principal regions: the peripheral rim of cortex and the central medulla. The two kidneys receive about 25% of cardiac output. They are protected in the retroperitoneal space by the renal fat pad and overlying ribs and muscle. Ureters. Blood vessels, lymph vessels, and nerves enter and leave at the renal hilum. The renal arteries arise directly from the aorta, and the renal veins drain directly into the inferior vena cava. Kidney function is derived from the actions of about 1.3 million nephrons per kidney. These are the functional units. A capillary bed, the glomerulus, filters blood, and the filtrate is captured by Bowman's capsule. A portal system is formed when the blood flows through a second capillary bed surrounding the proximal and distal convoluted tubules and the loop of Henle. Most water and solutes are recovered by this second capillary bed. This filtrate is processed and finally gathered by collecting ducts that drain into the minor calyces, which merge to form major calyces. The filtrate then proceeds to the renal pelvis and finally the ureters. Pathophysiology. Acute kidney injury is defined as spontaneous deficit in kidney functions leading to urea retention and electrolyte imbalance. Etiologies of ACI can be divided based on pathophysiologic mechanisms into three broad categories: prerenal, intrinsic renal, and post-renal causes. Prerenal ACI is most common and typically results from hypovolemia. Intrinsic renal is due to damage to renal parenchyma. Post-renal ACI is usually result of an obstruction, may be due to stones or strictures. Nursing care plan for patient with acute kidney injury. Assessment. Possible evidence by intake greater than output. Oliguria, changes in urine-specific gravity. Venous distension, blood pressure, BP/central venous pressure, CVP. Changes. Generalized tissue edema, weight gain. Changes in mental status, restlessness. Decreased HB/hematocrit, HCT. Altered electrolytes, pulmonary congestion on X-ray. Nursing diagnosis. Excess fluid volume related to compromised regulatory mechanism, renal failure. Planning. Display appropriate urinary output with specific gravity/laboratory studies near normal, stable. Weight, vital signs within patient's normal range, and absence of edema. Intervention. Accurately record intake and output, INO, noting to include hidden fluids such as for antibiotic Additives, liquid medications, frozen treats, ice chips. Religiously measure gastrointestinal losses and estimate insensible losses, sweating, including wound drainage, nasogastric outputs, and diarrhea. Rationale: decrease in output to less than 400 ml per 24 hours may indicate acute failure, especially in high-risk patients. Accurate monitoring of INO is necessary for determining renal function and fluid replacement needs and reducing risk of fluid overload. Do note that hypervolemia usually occurs in a neuric phase of ARF and may mask the symptoms. Intervention: monitor urine-specific gravity. Rationale: measures the kidney's ability to concentrate urine. In intrarenal failure, specific gravity is usually equal to or less than 1.010, indicating loss of ability to concentrate the urine. Intervention: weigh daily at same time of day, on same scale, with same equipment and clothing. Rationale: daily body weight is best monitor of fluid status. A weight gain of more than 0.5 kg/day suggests fluid retention. Intervention: assess skin, face, dependent areas for edema. Evaluate degree of edema, on scale of +1 +4. Rationale: edema occurs primarily in dependent tissues of the body. Hands, feet, lumbosacral area. Patient can gain up to 10 pounds, 4.5 kilograms, of fluid before pitting edema is detected. Periorbital edema may be a presenting sign of this fluid shift because these fragile tissues are easily distended by even minimal fluid accumulation. Intervention: monitor heart rate, HR, BP, and JVD/CVP. Rationale: achycardia and hypertension can occur because of 1. Failure of the kidneys to excrete urine. 2. Excess fluid resuscitation during efforts to treat hypovolemia and/or hypotension or convert oliguric phase of renal failure. 3. Changes in the renin-angiotensin system. Invasive monitoring may be needed for assessing intravascular volume, especially in patients with poor cardiac function. Intervention: auscultate lung and heart sounds. Rationale: fluid overload may lead to pulmonary edema and HF evidenced by development of adventitious breath sounds. Extra heart sounds. Intervention: assess level of consciousness. Investigate changes in mentation. Presence of restlessness. Rationale: may reflect fluid shifts, accumulation of toxins, acidosis, electrolyte imbalances, or developing hypoxia. Intervention: scatter desired beverages throughout the 24-hour period and give various offering, hot, cold, frozen. Rationale: helps avoid periods without fluids, minimizes boredom of limited choices, and reduces sense of deprivation and thirst. Intervention: correct any reversible cause of ARF, replace blood loss, maximize cardiac output, discontinue nephrotoxic drug, relieve obstruction via surgery. Rationale: kidneys may be able to return to normal functioning, preventing or limiting residual effects. Intervention: use appropriate safety measures, raising side rails and restraints. Rationale: patient with CNS involvement may be dizzy and/or confused. Expected outcome: goal met. Urinary output within normal and signs within patient is in normal range and there are absence of edema. Monitor diagnostic studies. Blood urea nitrogen, BUN, creatinine, CR. Assess management of renal dysfunction. Both values may increase, but creatinine is a better indicator of renal function because it is not affected by hydration, diet, and tissue catabolism. Dialysis is usually indicated if ratio is higher than 10:1 or if therapy fails. To indicate fluid overload or metabolic acidosis. Urine sodium and CR. In ADN, tubular functional integrity is lost and sodium resorption is impaired, resulting in increased sodium excretion. Urine creatinine is usually decreased as serum creatinine elevates. Serum sodium. Hyponatremia may result from fluid overload, dilutional, or kidneys' inability to conserve sodium. Hypernatremia indicates total body water deficit. Serum potassium. Lack of renal excretion and/or selective retention of potassium to excrete excess hydrogen ions leads to hyperkalemia, requiring prompt intervention. HB/HCT. Decreased values may indicate hemodilution, hypervolemia, however. During prolonged failure, anemia frequently develops as a result of RBC loss. Other possible causes, active or occult hemorrhage, should also be evaluated. Serial chest X-rays. Increased cardiac size, prominent pulmonary vascular markings, pleural effusion. Congestion indicate acute responses to fluid overload or chronic changes associated with renal and heart failure. Administer and/or restrict fluids as indicated. Fluid management is usually calculated to replace output from all sources plus estimated insensible losses, metabolism, diaphoresis. Prerenal failure, azotemia, is treated with volume replacement and/or vasopressors. The oliguric patient with adequate circulating volume or fluid overload who is unresponsive to fluid restriction and diuretics requires dialysis. Note, during oliguric phase, push/pull therapy, push for fluids and diurese with diuretics, may be tried to stimulate kidney function. Administer medication as indicated. Diuretics, furosemide, Lasix, bumetanide, Bumex, torsemide, Dmadex, mannitol, osmitrol. Given early in oliguric phase of ARF in an effort to convert to non-oliguric phase, flush the tubular lumen of debris. Reduce hyperkalemia and promote adequate urine volume. Antihypertensives, clonidine, Catapres, methyldopa, Aldamate, prazosin, minipress. May be given to treat hypertension by counteracting effects of decreased renal blood flow and/or circulating volume overload. Calcium channel blockers. Given early in nephrotoxic ADN to reduce influx of calcium into kidney cells, thereby helping to maintain cell integrity and improve GFR. Prostaglandins. Vasodilatory effect may improve circulating volume and re-establish renal blood flow to aid in clearing nephrotoxic agents from nephrons. Insert indwelling catheter, as indicated. Catheterization excludes lower tract obstruction and provides means of accurate monitoring of urine output during acute phase. However, indwelling catheterization may be contraindicated because of increased risk of infection. Prepare for dialysis as indicated, hemodialysis, peritoneal dialysis, or continuous renal replacement therapy, CRRT. Done to correct volume overload, electrolyte, and acid-base imbalances, and to remove toxins. The type of dialysis chosen for ARF depends on the degree of hemodynamic compromise and patient's ability to withstand the procedure. During peritoneal dialysis, position the patient carefully, elevate the head of the bed. Doing so would reduce the pressure on the diaphragm and can aid in respiration. Watch out for complications such as peritonitis, atelectasis, hypokalemia, pneumonia, and/or shock. These complications are common for patients undergoing peritoneal dialysis. Innovations. Innovation in kidney diseases is not commensurate with the effect of these diseases on human health and mortality or innovation in other key therapeutic areas. A primary cause of the innovation is that kidney diseases disproportionately affect a demographic that is largely disenfranchised, lacking sufficient advocacy, public attention, and funding. A secondary and likely consequent cause is that the existing infrastructure supporting nephrology research pales in comparison with those for other internal medicine specialties, especially cardiology and oncology. Citing such inequities, however, is not enough. Changing the status quo will require a coordinated effort to identify and redress the existing deficits. Elucidate the pathophysiology of kidney disease. Biomarkers can enhance the understanding of disease pathogenesis and clinical course, help predict and identify unexpected safety concerns during early phases of drug development rather than in later, more costly phase 3 trials, serve as surrogate endpoints. Aggregate subjects at high risk of specific outcomes, and stratify subjects at the time of enrollment. Despite considerable effort, the kidney community has produced few biomarkers that have been adopted into clinical practice or that have been recognized for their potential to inform drug development. Partner with people with kidney diseases. Cancer, heart disease, and HIV/AIDS are diseases with highly motivated, organized, and effective patient advocacy. The kidney community can learn from this experience and build on past efforts to unify the patient voice and drive every aspect of the research enterprise. People with kidney diseases struggle to advocate for their own needs because of socio-demographic variables, including health literacy and economic status, health limitations caused by comorbid conditions, and even recognition of their condition. Awareness of CKD is low even in at-risk populations that have seen a physician in the last year. We must foster a culture where people with kidney diseases are empowered to advocate for their own needs. Patient engagement is essential for innovation in nephrology. Ideally, patient needs will inform and direct clinical trials, and patients will participate in clinical studies. An engaged patient base leads to reducing the costs associated with traditional clinical trials, such as those associated with patient recruitment and study startup times, because more patients want to participate. Innovative trial designs require collaboration with leaders in the patient community to build a patient-supported platform that is best positioned to participate in clinical trial enterprises. Create an infrastructure that increases clinical trial efficiency. The infrastructure needed to support clinical nephrology investigation is expansive and includes a well-trained workforce, properly positioned clinical research organizations and trial networks, patient registries, and databases that capture relevant data, and efficiently administered institutional review boards, IRBs. Clinical trials are costly. Standardizing data collection and shortening device and drug development timelines by improving patient access and selection will significantly reduce expenses. No amount of resources allocated to conducting studies in kidney diseases will satisfy the needs if we do not first create an efficient clinical trial enterprise. The need to transform our care delivery systems into learning health care systems, where research is embedded into clinical care, has been increasingly recognized. The adoption of new standard operating procedures could improve the productivity of the clinical trial enterprise. The adoption of new standard operating procedures could improve the productivity of the clinical trial enterprise. Although most institutions perform internal IRB review because of liability concerns, use of multiple IRBs is resource-intensive and may decrease human subject protections and disempower IRBs from making needed protocol changes. Use of central IRBs would eliminate redundancy, thus saving time and money while increasing human subject protections. Improve the design of clinical trials and clarify appropriate endpoints. Successful development programs require trials that more efficiently identify and enroll patients who are likely to benefit from the therapeutic intervention. Clinical trial design factors, such as pre-screening of patients and clear inclusion/exclusion criteria, must balance the desire to eliminate likely biologic non-responders who decrease trial efficiency with the need to rapidly accrue patients who are representative of the target population. Such design choices benefit from a sophisticated understanding of the pathophysiology of the disease process. In some circumstances, biomarkers can help drive such study enrichment. Improve coordination among all stakeholders. A coordination is needed where patients, investigators, caregivers, industry, and government can work together to increase understanding of pathophysiology, patient engagement, research infrastructure and efficiency, and trial design and conduct. Aim to overcome barriers to innovation in nephrology. To enhance the development of novel medical products for meaningful patient outcomes, every stakeholder must embrace 5 interconnected goals. Support the development of diagnostic biomarkers. Increase patient engagement to advance awareness and funding of kidney disease. Expand the infrastructure supporting clinical trials, including the development of patient registries. Optimize endpoints and design to enhance clinical trial efficiency. Enhance collaboration with the government to overcome obstacles that inhibit innovation and advances in care. In a worth-based model of care, medical services suppliers are allowed to be more creative about improving consideration for the entire patient, while simultaneously diminishing generally speaking expenses. In the previous decade, we have seen the quantity of renal patients taking an interest in new models of significant worth-based consideration, developed by the many thousands. New proposition to change the manner in which the dialysis is paid for with the possibility to improve lives, quickening our endeavors to lessen hospitalizations and readmissions. At the point when a clinical supplier makes the best choice and evades a medical clinic stay in a charge for administration climate, the monetary advantages ordinarily accumulate to the payer. The medical services financial aspects change to the advantage of our patients in a worth-based program. For instance, another inventive catheter cap has been appeared to lessen contaminations. These more costly covers are cost-restrictive in a charge for administration model. However, in a worth-based model, we would be allowed to actualize this greater expense cap to decrease diseases and hospitalizations and be remunerated for improving in general patient results. We are at an energizing time for the transition to a steam-based consideration for individuals with renal disease, as the achievement of these new projects is being figured it out. This work to all the more likely arrange care is presently prepared to fall off the test track and hit the street. Advancement isn't simply conceivable, it's goal.